Good afternoon. Welcome to Regional Distance Learning Clinical Seminar Series. Today's topic is nutritional care of HIV-infected children and counseling for children and adolescents living with HIV. And speaker Dr. Abarna T. Dr. Abarna has completed MD in Pediatrics from GIP-MER Pondicherry and is currently pursuing DM in Pediatric Clinical Immunology and Rheumatology from PGI Chandigarh. She has made her various presentations at national and international conferences. Now I request Dr. Abarna to start the session. Thank you.
Good afternoon, everyone. I hope everyone can hear me.
Yes, ma'am.
Okay. So today I'm going to talk about the nutritional and counseling session in retro children's. Can we go on? Just, yeah. So the main objectives of this session are assessment. We should know how to assess the nutrition status in the children living with HIV and how to manage it, and counseling of the children and adolescents living with the HIV. And we should create a friendly environment in the ART center, and how to counsel them, how to counsel the parents. So these are the main things that we are going to deal today. So next slide. So coming to the nutrition care of the HIV infected children. Next slide. So we should know that malnutrition and HIV follows a vicious cycle, and they both can go hand in hand together. So they both can cause poor nutritional status, weight loss, muscle wasting, and micronutrients deficiency. They then lead to impaired immune system, leading to multiple infections, and which leads to increased vulnerability to infections and increased frequencies of other opportunistic infections, which further lead to worsening in the nutritional status. So we have to handle both the retroviral infection and also the nutritional status in these children's. Next child. So we should know how to assess the nutritional status in this in these children. So we should know, we should initially, when a child comes, we should ask the dietary history, and we should assess how the child's growth pattern is, whether it's growing normally or it is flattering or it is going down. And we should ensure good safety practices, food practices in the family, and we should avoid the opportunistic infections. Next slide. So these are the growth charts. Most of you must be aware of the WHO growth charts. So these we access from the NACO charts also, or also you can download from online the WHO growth charts. The blue is for the boys and the pink ones are for the girls. These are birth to 5 years ka chart. Next slide. So these are the WHO length or height for age chart. Likewise, I told blue is for the boys and pink is for the girls. It is still 5 years. Next slide. These are the WHO weight for length or weight for height chart. These are these chart is you should to see whether there is acute severe malnutrition is there or not. So generally, if height and weight both are low, it is usually we have to look for the weight for height to call it is just acute malnutrition or chronic malnutrition. So these are also available online, and these are WHO good charts. Next slide. So these are the patterns. So if you see the first, it is like a normal or well-growing child. You can see the growth is growing up. So this is called flattening. That means like sudden acute insult has happened. After that, the growth has stopped in this child. So you have to do a clinical assessment, urgent clinical assessment in this child. And the third chart is the one that it means the child is losing weight. So from whatever the child had previously, and now it is actually started to fall. So it means like the child has like some acute severe illness that has leading to lose weight. So we have to abrupt intervene at this point and evaluate the child. Next slide. Coming to the we have to classify the child. Based on that only we can treat it, whether they are like severe acute malnutrition or just poor weight gain, or whether they are growing appropriately like that. So coming to the severe malnutrition, first part is it's more or like how severe acute malnutrition or SAM definition we generally see for all the children. No? It looks similar to that. So it is like we have to look in severe malnutrition. We have to look for the signs of severe visible wasting, edema and bilateral feet, and weight for height less than -3 Z score, or midterm circumferences less than 11.5 centimeter, or 1 millimeter in children to 6 to 60 months, and these centimeters vary for till 5 to 9 years and then 10 to 14 years. So these are the things, if you see, you can classify them as severe malnutrition. If only just poor weight gain, if you want to classify them, then you have to check the weight. If the weight is like less than -3 z score or underweight, that is weight for age is less than -2 z score, or confirmed weight loss of more than 5% since the last visit, and there is a growth curve flattering it, that is like the second curve I have shown. No? If that is there, then you classify them as poor weight gain. So if the child has like the first chart, like that means they're gaining adequate weight, then it's called growing appropriate child. You classify them as growing appropriately. Next is if the child has like a chronic lung disease or a TB or a persistent diarrhea or any other chronic opportunistic infection, then we should intervene them, because many of these children, no, they'll have growth flattering, or like they'll have like the third curve, like how they will have loss. So they should have an additional nutrition supplement in those childs. Next child. So these are the calorie requirements based on the classification criteria. So these are the general, based on the age wise, they have mentioned the calorie requiremements. So the daily energy requirement of HIV uninfected children, initially we should know how much is it. So it increases in case of HIV uninfected along with if they are asymptomatic, they require additional 10% compared to the normal children. So if a child that has an HIV infected, even though they are asymptomatic, they'll need a little bit extra calorie compared to the normal children. So if they have like a poor weight gain, then the additional requirement will be like 20% more than the normal children. But if they have a severe malnutrition, we have to give up to 50 to 100% of additional requirement. So these are the baseline. You guys know, most of you guys know the baseline. So we can calculate based on the whether the child is asymptomatic or child is having some poor weight gain or SAM, we can just calculate based on it. So we just need to know how much extra we have to give for the child. So normal basic calorie requirement, we can calculate it. So based on that, if a child is asymptomatic, if a retro child who are asymptomatic, we have to give 10% additional energy. If they have poor weight gain, we have to give them 20% additional energy. If they have severe malnutrition, we have to give more than 50% of additional energy. Next slide. Next slide. Coming to the nutritional management, so we have to look for the signs of visible wasting and bilateral periodema, the severe impaired growth. These are the signs for severe malnutrition. Then we have to evaluate what are the causes for it and what are the implications that they have. So one main thing we have initially seen itself, like the infection and the malnutrition go hand in hand, and they have a vicious cycle. So we have to look for any opportunistic infection like TB is there or not, or any other infection we have to look for. You have to look for anemia. If anemia is there, you have to correct it. If there are any side effects of the drugs are there, you have to correct it. Main thing is like if we have started the child on ARV, if they have poor adherence or if they have treatment failure or resistant to the ART, then those themselves can cause a severe acute malnutrition. So we should treat the causes of malnutrition in those children. Then you have to add supplementary food in them. Next slide. So additional energy requirements based on the age they have given, how much to be given or not. So like I previously told, in case of asymptomatic children with adequate goal, we have to, even with the retropositive child, we have to give 10% additional energy compared to the normal growing child. In case of poor weight gain, we have to give 20 to 30%, and severe malnourished, we have to give 50 to 100%. So they have given in calories requirement is, in case of asymptomatic child, we have to give to 60 to 70 kilocalorie per day. In case of poor weight gain, we have to give 120 to 150 kilocalorie per day. So how to supplement this extra food? So that they have mentioned that we can add some 2 teaspoons of oil, or we know oil and fat, they have fat content, have high excess calories, and then sugars, they both have a high excess calories. So in the normal food that we take, then we can add extra of the oil and the sugars. So these we can, if we are not able to know how much to add, you can just go through the charts before prescribing for them also, how much exactly the spoons. So in case of 60 to 70 kilocalorie, if you want to give, you have to give teaspoons of edible oil and 1 teaspoon of sugar to the porridge or the some whatever the food you are giving. In case of the poor weight gain, then you have to give 2 teaspoons of edible oil and 1 to 2 teaspoons of sugar, and then you should add we should add it twice daily in that. Then coming to the severely malnourished, this is like a therapeutic feeding practice as per the national guidelines. We have to give more than 150 kilocalories we have to achieve, try to attain in the severe malnourished child. Next slide. So this is like age wise classification, how much to be given for each child. So in case of 12 to 23 months, if they fall in the first asymptomatic group, you can just add the like I told, 2 teaspoons of oil and 2 teaspoons of sugar we can add, or one medium banana we can give. But in case of like if they fall in the second category, we have to give an extra cup of full cream milk with 1 teaspoon of sugar, or 2 big idlis, or 2 slices of bread with butter we have to give. In case of third category, the severe malnourished, we have to follow the national guidelines for achievement. Next slide. So in case of 2 to 5 years, you have to add a extra, if they fall in the first category, you have to add an extra cup of milk, or a sweetened curd, or a one extra roti with vegetables, or one paratha, whatever the child is preferable to eat, you can add like that. In case of if they fall in the second category, we can give puris, 2 puris with vegetables, 1 cup of porridge, or 2 pieces of chikki we can give. Uh, and the third slide is based on the national guidelines we have to give. Next slide. So this is 6 to 9 years. So 6 to 9 years, we can, if for the first category, we can add an extra cup of milk, or a full cream, or an egg omelette, or extra roti, or vegetable parathas. So likewise, in second category, we can add extra food like stuffed parathas, or paratha with curd, or halwa, or poha we can give. Next. So this is like 10 to 14 years. Similarly, you can go through with the charts, like how much to give exactly, the calories and the food items, what are we can give. Next slides. So those are the nutritional supplements. Coming to the other micronutrient supplements, we always know in a case of SAM management also, we will be giving micronutrient supplements. And in case of vitamin A, for 6 to 12 months, we have to give 1 lakh international units orally. And in case of 1 to 5 years, 2 lakh international orally once. And then for children beyond 5 years of age, vitamin A, like a normal syrup we'll give, no zincovit or anything, that should have some vitamin A supplementation that should be added in it. And then next is like deworming is important, we should given, because like worm infestation is important cause of anemia in these patients. So we have to deworm them every 6 months. So we have to give a single dose of albendazole orally every 6 months after 5 years of life in these children. And the next is like cotrimoxazole prophylaxis. When they are severely malnourished, we have to continue them on cotrimoxazole prophylaxis. If they have a recent history of diarrhea, we have to give ORS during the acute illness, following which we have to add zinc in supplementation in them. We have to give 20 mg daily for 2 weeks. And we should encourage play therapy, age appropriate activities, then we should early stimulation, all those things we have to give. And then we should administer routine immunization in them also. Next slide. Coming to the nutritional counseling, apart from the need for additional food, we should tell them like how to attain these needs, and then how to prepare a safe food, and water and safe water and food storage methods, and hygiene issues we should address during these counseling sessions. Next. So we should tell them how to wash your hands, and how to wash it before and after going to the toilet, and then utensils should be washed properly, and then the kitchen areas and where they make food, that should be kept clean and then washed properly. They should be told like we should uh, cook the food, that is like a raw meat, poultry or fish should be cooked separately compared to the vegetables. They should make sure they cook it properly. If they are storing it in a fridge, they should make sure that they thaw it and recook it before eating it. And we should make sure that they use different utensils for cutting fruits and vegetables, and or alive meat. So all these things should be taught to them. And then how well they should be cooked. So like milk should be like a boiled, and water should be boiled before drinking, and meat should be cooked well so that they won't get any infection. So these two should be taught them. We should teach them, and then we should make sure we should ensure that they do all these things, and we should make sure that they understand the importance of all these things. Next slide. So next is like keep food at safe temperature. That means like There are few food that if they kept open, they can have a lot of infection. So they should make sure that they keep in, say, the fridge. Once it's out of the fridge, they should heat it before eating it. So they should not refrigerate it also for a longer time. So these things should be taught to them, how to deal with all these things. They should be taught, I mean, especially to the caregivers or to the parents. And we should tell them the water should be like a fresh water, and then they should be cleaned. And I mean, the utensils in which they boil the water should be clean, and they should boil it for adequate time to use it. Only pasteurized milk should be given, and even with the pasteurized milk, they have to boil the milk. All these things should be told. Next slide. These are the feeding recommendation for the sick child. So they are also categorized into 4 categories: up to 6 months, 6 months to 12 months, 12 months to 2 years, more than 2 years, or 2 years and older. So till 6 months, they should encourage breastfeeding continuously. Even if the child is sick, or child is having diarrhea or pneumonia, whatever it is, they make sure like they should continue them on feeding. So if it's because child is having fever, if they stop feeding it, the child can go for hypoglycemia or other issues also. So when they are up to 6 months of age, we should continue on feeding. No other feed supplementation should be given. Try to be on only breast milk. So next category is 6 months to 12 months. So breastfeed, we should given as often the child wants. We can add other things like mashed food items like mashed bread, biscuits, or sweetened undiluted milk we can give. So these are the food items that what are can be supplementation. You can go through it. There is a long list of it. Next is 12 months to 2 years. Breastfeed, if they are continuing, if they have not stopped, if this mother is still giving getting milk, then we can continue breastfeeding up to 2 years of life. So we can give intermittent breastfeeding along with the other food items. So these are the food items that I have mentioned, like what are like can be given and how much quantity to be given. So this is there in the booklet, and you can go through it. If the child is 2 years or older, we should give family foods at 3 meals each day, also twice daily, and we should give nutritional food between the meals, like banana, biscuit, chicky, mango, or papaya as snacks. Next slide. So these are the cut short they have given, like how to remember it. So up to 6 months, we have to continue breastfeeding if the child is sick. For 6 months to 12 months, so we have to keep the child in your lap, and then you should try, if they are able to take, they can, or else you have to feed. And you should be, your hand should be washed with the soap and water before feeding the child. And we should give 3 times per day if breastfeeding is there, plus snacks we should give the additional feeding. If the child is not breastfeeding, we should give the food is like 5 times per day. So, in case of 12 months to 2 years, you have to sit by the side of the child, and then you should give the food to the child and make sure that the child washes the hands before eating. Okay. So these are the things like how to have a clean, safety environment, and how much to give supplement food in this child. Next slide. So these are the monitoring and how to follow up these childs based on what age they are and then how well they are growing. So if a child who's well and growing appropriately, you should monitor them every 2 to 3 months, maybe monthly if they have received routine cotrimoxazole or micronutrients or other supplementation, including ART if they need. If a child is on ART and the child is gaining weight and no other problems, we can monitor for 3 months. If child is not gaining weight, we should give a monitor and monitor them every 2 to 4 weeks. That is, we should call them for follow-up every 2 to 4 weeks. If a child who has a chronically increased nutrition needs but investigations and no other active issues, so tell the we can tell the caregivers that the child should be followed up every 2 to 3 months. But if the child has any issues, you can ask them to come visit us as early as possible also. If a child is having a poor weight gain, first we should be 1 to 2 weeks. Then we can tell them like 1 to 2 months they can child can come. But we can tell them like if any acute illness, then the child can visit the healthcare. If a child who's unwell and are showing signs of growth flattening or has a recent diarrheal illness, you should call them 2 to 4 weeks. But if the child may require a frequent visit if the clinical status is not good or the support system is not very good. if the child is malnourished or other signs of disease progression is there, with the history of recent severe weight loss or recent diarrheal illness, it's there, you should ask them to visit every weekly till they have started to gain appropriate weight, or the diarrheal illnesses subsides, or the other chronic illnesses are getting better. When a child is severely malnourished with a medical complication or no appetite is there, the child is requiring hospital admission. Next slide. Next is like we have to know how to counsel these children. We have like separate counseling session for the caregivers, the children, the adolescents living with retro. Next. So what are the challenges we face in this? Are the difficult counseling session is always a difficulty even in a normal patients, but retro patients, like, it is much more difficult. So we should initially tell them what the challenge. These session includes the challenges faced while counseling a child living with HIV, child-friendly ART centers, child-centric counseling, and counseling the caregivers and the children, treatment preparedness, adherence, and follow-up counseling. Next. So caregiver related challenges. So we should tell them about the one issue is like most of the children who has retro, or the parents will be either sick, they'll also be hospitalized, or that they will not be alive. There must be frequent changes. Initially mother might be taking care of it, sometimes father, or sometimes grandmother, because like one of them, most of the parents will also be sick many a time, so they'll be taken care by some caregivers in the family who's not sick, or sometimes they'll be in an orphanage. So these are the once you counsel one of them, and next time or the further time they may not come, so it's like every time whenever new people come, you have to have the patience to counsel the caregivers. And if it is not their own babies, and if the patient is taken care by some other attender in the family, their attitudes and beliefs and habits also change towards the babies, and then we should make sure that they don't develop any such attitudes towards the baby. Next challenges are child related challenges. uh, Dependency on adult for treatment, poor attention span of the child, difficulty experienced by the child in communicating the feelings and thoughts. Like small child, they, even though they get feel sick or they feel unusual after the drugs or anything, they won't be able to express it, and they'll have poor physical growth. They won't be able to do things like the peers, and they don't look as similar as the peers because they have a poor growth and all. Home environment related issues are the major thing, is like the economic constraint and discrimination that happens in the family. Next slide. So how to address these challenges? So we have to support the child and caregivers through the sensitive and caring counseling. So we should the counseling session is depending upon the age, the developmental status, and how they are able to understand it, their economic, and then their education, parents' education status, and their social circumstances. Based on all of this, the counseling session for each patient is varies, and we should individualize the counseling session. So by adapting the counseling to change the needs as the child grows older and progress through various stage of development. So we should, once a child, when they are very young, they won't be able to understand all these things, what's happening and everything. But once they become adolescent, we have to we should ensure that they understand that this is, and how to deal with it, and how to take care of their own care. So these kind of counseling will varies once the child grows also, and if the caregivers are also changing, the counseling session also varies significantly. So we should have a we should always identify in a family who's the primary caregiver, and we should make sure we counsel them. But if at all something happens to the primary caregiver, there should be a backup secondary caregiver. Whenever the primary caregiver is not coming due to some emergencies, the secondary caregiver should come, so that we should make sure that we counsel both of them. Okay. Next is by sensitively addressing the challenges of coping with adherence to the lifelong treatment, issues of disclosure, confidentiality, stigma, discriminations, all the environmental issue. So all these things we should address in our counseling sessions. Next slide. Next. So how to create a safe environment for the children? So we should counsel the children to cope with their infection, look after their healthy property. We should counsel caregivers to support the children, and we should provide a comfortable and friendly environment at the center for children and caregivers. Next slide. So, what are the ideas for creating a child-friendly ART center in the resource-limited settings? So, we should have a separate room for counseling session for the children. We should have small chats for the children. We should have a drawing papers, crayons, and art material so that they can uh, go through all those things. We should have storybooks, games, and toys for children. There should be a wall displaying paintings done by these children also. There should be a blackboard and a chalk placed at the child's eye level in the corner of waiting area so that whenever they can express their feelings and creativity in those things. Next. Child-centered counseling is the next topic. Next. So initially we should develop a good rapport. For developing this rapport only, we have told that there should be toys, chocolates, and uh, crayons and boards so that you can initially let them play with it, and then you slowly create a rapport, talk with them, and get a rapport. You should focus on the child's needs. It should be tailored to the child's physical and psychological development. Our counseling session should be promoting the child's potential and ability. It should be the counseling session should build a self-esteem in the children, and we should respect the child's identity and emotions. And this session should protect it's based on the best interest of the child, including the right to participate in the decision that affect him or her, no non-discrimination and confidentiality of the information. So we should, whenever doing this counseling, we should always involve the child and the child's caregiver also. Next. So these are the counseling skills we have to. I'm going to talk about soon. So wrap over. So when a child comes, we should greet the child, introduce yourself and who you are, and you should try to talk in their level of intelligence, uh, and you should tell them, and then try to play or a little contact with them. You should do. We should try to clear their fears and misconception about the counseling. We should ha- uh, no, we should tell the child like why and what concerns, why this counseling session is needed, and we should make sure that we have maintained the confidentiality of the child. We should have a neutral play and art activities to build a therapeutic relationship and spirit of collaboration also. Next. So we should listen to the child's verbal and non-verbal communication whenever they try to share something about them or about the experience that they have had in the past. And we should always try to be supportive, even though we know like everybody has their different beliefs, but we should not to be more argumentative, and we should tell the child to complete his or her thought, and then we should always be supportive of it. Next. We should have a good recognizing and acknowledging emotions of the child. So whenever child experiences difficult experiences or emotions, we should make sure we understand them. We should slowly listen to them. We should have some empathy. We should support the patient's feeling, and we should comfort them. So if we are giving any suggestion or advice provided, that should be in a very, we should acknowledge the child's emotion. So whenever the advice we are giving, it should be like we should understand their emotions and acknowledge the emotion, and based on that only we should give suggestion or advice. Next. So whatever the child or the caregiver, whatever they are saying, we should accept it. We should understand it in what thought process they have, and then we should acknowledge it, and then we should give a non-judgmental attitude towards it. And we all know like everybody has different belief and different practices, but whatever their practices, we should able to understand them. We should everybody has different views, so we should acknowledge it, and then we should give a non-judgmental suggestions or advice to them. Next. So whenever we are having questioning, we should uh, it should be like in a child-centric, well understanding, or it's in an empathetic way, not in a very authoritative or argumentative questioning should not be there. A combination of open and closed-ended question may be used to elicit information from the children. So, but we should always try to understand the children's perspective and allow them to tell their own stories in their own way and whatever the description and narration they want to use it. Okay. So next. So next is the counseling the caregivers and child for lifelong ART. Next. So first is like we have to there are 3 stages for counseling of ART. So first is the preparedness for counseling. Then we should tell them like they should adhere to the counseling so that they know that lifelong ART is needed, and they'll whenever they have small issues also then you can help them and address it. Then follow-up counseling. So there are 3 stages of counseling. One is preparedness for counseling, one is adherence to counseling, one is follow-up counseling. Next. So treatment preparedness counseling. So this includes educating and preparing the child and the caregiver for the lifelong therapy or a long-term treatment in these conditions. It is usually crucial for the adherence and the successful treatment outcome. This preparedness itself may take us several sessions. It is necessary to evaluate the child's social environment, and then we should identify clearly the caregivers who can understand the prognosis of HIV and the implication of ART therapy in these children. So we should address both the children and the adults separately and make sure they understand it. So the major difference between the preparedness counseling for the adults and children, since our children are dependent on caregivers for treatment and counseling for children, so the preparedness will include the caregivers counseling mainly. Next. So counseling of the caregivers. So we should identify who's the primary caregiver. Usually parents, but it can be others also. If the parents is also affected and they are sick or they have lost the parents, or sometimes it can be from somebody from orphanage also. And we should always check even the primary once one primary caregiver, and you should have a backup of secondary caregiver also. So we should tell them the advantages and limitation of ART, implication of ART being a lifelong therapy, importance of adherence, and the knowledge of drug toxicities and storage of drugs must be explained. You should help them to deal with the personal guilt and worry, as well as acknowledge the emotional needs of the parent, and you should give families needs some understanding and accepting the illness, and it takes a longer time, so we should give them some time to understand all these things and make sure they understand the basis of this treatment and lifelong treatment. So we should sensitize the caregiver about the disclosure of HIV status and this is information to the affected child. Disclosure to a child needs to be age appropriate and according to his or her level of understanding. Next. So there are 5 ways in the treatment preparedness. So initial is assess. We should assess the patient and caregivers or the patient's knowledge and the understanding towards it and how much they can understand the treatment and everything. We should assist in developing a treatment, and then we should make sure that they are added to the plan. Advice is third is advice. We should tell them how ART works and need for a long term this thing, and then we should tell them like how important is adherence and regular follow up visits. We should try to aim for 100% adherence. We should arrange for medical investigation and appropriate referrals. Agree is like both child and caregivers and both understand is accept and agrees to the treatment plan, and there should be 100% adherence to the lifelong treatment. Next. So we should tell them where, what, when, and how, and who about the ART medicines. What is like medicine will be given as pill or syrup, and the shape and color, how it is to be given, and how much dose. Explain the dose that must be repeated. You should explain the patient that if a child vomits, you should give repeat the dose within 30 minutes. So when it should be given, so and how frequently it should be given, so these things has to be explained to them. So we should tell them whenever they get a drug, you should make sure you should explain to them properly like this tablet is either a one tablet or a half tablet, or it should be taken in the morning or in the afternoon, like that only you should explain properly to them. And we should identify who's the caregiver in the family, and you should explain properly to the caregiver and the secondary caregiver also. Next. Next. So we initially, when we start an ART therapy, we should explain to them that every drug has a side effect. So even if a normal drug, any medicines you take, they have some minor amount of side effect is there. So we should tell them when you start an ART test, they'll definitely have some minor side effects and some major side effects. So for minor side effect like nausea, headache, abdominal discomfort is there, you should tell them how to deal with it at home based care. If they have some serious illness, they should be able to identify which is minor side effect and which are major side effect, and when to refer to the hospital. They should advise and counsel regarding it. Next. Next is adherence to counseling. So it is we should tell them that treatment adherence is very, very important for the viral suppression. So we should educate both the child and the caregivers about the adherence to the ART at the time of initiation itself, and during every subsequent visit we should ensure that they understand it. And we should always, it is very, very important that we should regularly check whether their child has finished. We should make sure that the child or the caregiver should bring the empty packets, so that we know that they have strictly adhered to it. It is essential to involve the child in adherence assessment, so that he or she also realize that adherence to the drug is very, very important in these cases. We should have an interactive methods such as pill charts or storytelling with the children during these sessions. We can suggest various ART reminder tools, including calendars, alarms, SMSs, reminders, refill boxes, or pill chart. We can suggest them to use all of this, so that they be able to know when to take the medicine. So we should always have like an alarm that shows like some 15 to 20 minutes before we can the child has to take the pill. Next. So common barriers. What are the common barriers why the child, some patients have very poor adherence to ARTs? There are some child related factors, there are caregiver related factors. In child related factors, like they are dependent on adults only basically. Likes and dislikes for medicines, some emotional issues, using medicines to manipulate adults, other infections and medications. In case of caregiver related factors, knowledge and understanding of treatment and its implications very, very important. If they don't have the knowledge, they don't give adequate drugs. Misconception regarding treatment should be is one of the important barrier. Health, some stupid health beliefs, some daily routines and natures and timing of job, all because of this they may try to forget it. Attitude towards adherence, some repeated changes in caregivers, because in case of orphanage and all, if you see like one die might be taking care today and somebody else will come tomorrow, so they may not know like what time to be given and what exactly the drug to be given. So this may lead to I mean discontinuation the drug in one or for a few days. And also it depends upon the how good the relationship with the children, also the caregivers relationship with the children. Next slide. Coming to the follow-up counseling. So children living with HIV may get tired of taking medicine. Usually it occurs after about 2 years. So these are one of the barrier for adherence to ART therapy. So signs in the form of marked changes in the confidence levels and attitude towards the treatment, and expression of feeling bad or for being the only one taking medicines among his peers. So these may affect the adherence to the ART therapy. Symptoms of psychological distress in the form of anxiety, depression, fears may be apparent, and they lead to poor school performances. Caregiver may also face adherence fatigue and feel tired of administering and supervising medications. So adherence fatigue related complication needs to be taken seriously. So every time when you have a counseling session, we should talk to them how they feel about taking ART and how they are doing in schools, so that we will able to identify the adherence fatigues in these children. Next slide. So next is the how we have to disclose HIV diagnosis to the children living with HIV. Next. So the type and the time of disclosure varies based on the patient's age. So initiating disclosure we will usually give for 4 to 6 years. So when the child is curious about many issues and concept of illness and wellness, so this time we can disclose. In case of partial disclosure at 7 to 11 years we can do when the child is aware that he or she or the parent has a chronic illness and is taking daily medication for it. For a child more than 12 years of age, you should give a full disclosure. That when a child can completely understand it, we should give a full disclosure. Next. So these are some pictorial representations like based on the age. So for a 3 to 6 years, you can just tell them like you are not well. So if you want to play, you should be well. For that, you need to take medicine. So instead of telling what they have, you can just tell them the child is ill sick and then they need medications for a long time. For 6 to 9 years child, you should tell them that they have a germs in some infection or germs inside your body. For the germs is making you feel sick often, and to kill that germ, you need to take medicine every day. So the germ will become strong if you don't take medicines. So they should be told in a such way that they understand for their age group. In the case of 9 to 12 years, you should tell them there's a germ in your body. It reduces your body's ability to fight other infections. We cannot remove it from your body, but we can control it so that they, by taking long-term medications, and we should take medications regularly. So this helps in a little bit of adherence also in this age group. Next slide. After 12 years, we generally disclose full disclosure, and when they are able to understand it, we should give full disclosure. So next is about the preparing the parents or caregivers for providing HIV disclosure. So it is important to know what level of knowledge the caregiver has about this illness before planning for HIV disclosures. And we should provide the basic information about the HIV. How does one get HIV? What are the treatment options? How can we manage the symptoms? The importance of adherence to the treatment, that and it requires a long-term treatment. All these things we should initially assess it. If they have a chance to ask questions and doubts and clarify their doubts, we should let them ask and then clarify it in a very polite way. Next. So next is explaining the need to disclose. So it is important to explain what the consequences can be of keeping the information from the child. Children, even when not provided the information directly, can sense some stressful situation around them. So they may ask questions directly. Sometimes they may not ask, and they'll try to overhear when somebody is talking, and they try to learn more about it, and all these things can happen. The unprocessed thoughts, doubts, and questions will only make people anxious and fearful. Similarly, given the fact that there is a lot of stigma around HIV, in case the disclosure is not made by the parent but by a peer, a neighbor, or a stranger in an abrupt or sudden way, it may be shocking and hard for the child to process. So it is better for the caregiver and the counselor to give open disclosures in a much more better way. Next. So, next is to about the addressing the parents or caregivers' fears and concerns. The parents may still have concerns and fears about disclosures. It is a common belief that children will not understand if told, as they are not mature enough, or it will scare the children if they are told about the illness, and it will cause worry and anxiety in them. Therefore, you diversionist methods or completely avoiding the subject feels like an easier option. So parents should be prepared to give a limited age-appropriate information to the child without going into all possible implications at the time of disclosure. Like I initially, there was one more slide we have put now, in which we have told up to 3 to 6 years how to disclose them, 3 to 6 to 9 years how to disclose them, telling that there is a germs inside that they need a long-term medication. Like that, we can give a little information. Once the child grows, we can give a full information also. Next slide. So deciding how, when, and by whom disclosure will be implemented. So disclosure can either be made by the counselor or the parent. It depends on the circumstances and the comfort of the child. In case the parents carry out the disclosure process, the counselor can prepare them with the right script to make disclosure to the child in an age-appropriate manner and a graded manner in order to overwhelm the child. The counselor remains in the background and helps to manage any difficulties that may arise after disclosure. Next. So other counseling messages. Next. So nutritional food safe handling is the one that I have detailedly explained before. Like We should make sure that we should wash hands and keep a clean environment around the cooking things, and then we should always advise them to wash their hands with the soap and water and cover the nose during coughing, sneezing, and then we should make sure that the open wounds, we should make sure like they should not go into contact with other people with the open wounds. Coming to the immunization history, we should encourage and ensure a timely immunization for children living with HIV. If the CD4 count is above 15%, they can be safely immunized even with the live vaccines. Planning for the future of the child living with HIV. When a caregivers are parents who are on ART themselves, it is important to alert them to the need to plan for the future of the child in case of their own untimely death. It is also important to enable the parent to identify who will be the legal guardian and caregiver in such event. Next, counseling of the adolescent living with HIV. This is like adolescent group is between 10 to 19 years. So based on the whether they are vertically transmitted or horizontally transmitted, it differs. Next. So if it is a vertically transmitted, that is they have acquired during the neonatal period from the parents. They have likely to have an advanced HIV stage when they become adolescent. They are more likely to have an opportunity infection compared to the horizontally infected adolescents, and they'll have a growth and development usually affected when compared to the horizontally infected adolescents. They'll have a higher mortality rate because the disease would have progressed in them compared to the newly acquired adolescent with retro. So disclosure of HIV status would be usually partial or none because they would have been having for a longer time. So if but in case of horizontally infected children, they likely to know the status by that time when they were actually identified. In case of vertically infected patient, they would already have experienced multiple HIV related losses in the family or in the parents. So in case of horizontally infected, they usually don't have transmitter from family, so they all will be well, but the social and clinical support system won't be good enough. So in case of vertically infected child, they have might have experienced a lot of stigmas in life in during the early period. In case of horizontally infected adolescent, they might experience a lot of stigmas later, and it can be exaggerated related to drug use or sexuality, etc. Next. So, what are the challenges faced by adults living with HIV? In case of they have a new cognitive capacity, they have a evolving decision capacity, they have struggle for independence, questions to the authorities like parents or doctors, need to identify with the peers, preoccupation with the self images, risk taking behavior. These are the challenges of the adolescent. What are the challenges of HIVs are? HIV associated stigma and discrimination, chronic disease requiring daily medication, long-term morbidities related to both HIV itself and its treatment, associated adverse socioeconomic conditions. These are the challenges of HIV. These two go hand in hand in patient of adults living with HIV. Next slide. So, what are the challenges faced by the vertically infected adolescents? So, these are the ones that acquired from maternal transmission. So, they may experience a poor physical growth, delayed puberty, impaired bone health. They may have a delayed developmental delay, cognitive memory impairment. They may not do well in schools. They have a long-term HIV-related morbidities. They may have increased psychiatric or behavioral problems. So many adolescents may not know their own HIV status and that they are the parents. They are required to take daily medication for ART and the need for the and during this adolescent period they started to question why I'm taking daily medications. The challenges related to long-term duration of ART including faltering of adherence, treatment failure, treatment-related side effects, and likely complex ART regimens are commonly used and seen. And they'll have HIV-associated stigma and discrimination also. Next. Challenges faced by the horizontally infected adolescent. These are the newly acquired adolescent people who was acquired not by maternal transmission. So many of them live on the fringes of the society, hiding their sexuality, occupation, or gender from their families and peers. They have difficult to reach due to criminalization of drug use, sex work, consensual sex between males, and fear of arrest and abuse if the behavior is discovered. They may face challenges in disclosing their status to the caregivers or family. Engagement and retention in HIV care is also a big challenge. There is a delayed detection of HIV due to low index of suspicion in a largely asymptomatic adolescents, the lack of adequate youth-friendly voluntary testing facilities, and requirement of parental consent for HIV testing before they reach the age of 18 years. They also loss to follow-up is also high in this group. Next. Common challenges faced by the vertical both these groups. They have increased likelihood of adverse family and social environment with the poor support. They have difficulty in accepting and learning to cope with their diagnosis, and it impacts various aspects of their life. They'll have increased mental stress and the risk of acquiring deviant and aggressive behavior. They have higher chance of hindered education and career related challenges also. They have difficulty in coping with relationship following protective sexual practices, and greater risk of unwanted pregnancies also. Next, how to counsel these patients. Next. So we should, the counseling needs to be in three. One is care and treatment, sex and HIV, and life skills. So we should tell them, we should clearly tell them about HIV and the need for lifelong treatment and treatment adherence, and disclosures, healthy living and nutrition. Uh, Pregnancy prevention, sex and relationship, and growing up and changing behavior, we have to concentrate regarding it. We have to deal with their communication skills, handling stigmas, discrimination, decision making, and planning for future. Next. So what are the do's and don'ts in these children? So we should be truthful about what you know and what you don't know. So we should give a accurate information and not an inaccurate information, and we should not scare them. Should be very professional and technically competent in them. We should use words and concepts that they can understand and relate to, and that they can relate to it. We should use pictures and flip charts to explain them. We should treat them with respect in terms of how you speak and act. We should give them all information or choices and help them to decide what to do. We should treat all adolescents equally. You should be understanding and supportive even if you do not approve with their behavior. You should accept they may choose their individuality in dress or language also. We should avoid giving inaccurate information. We should avoid threatening to break confidentiality for their own good. You should avoid giving them only the information that you think that they will understand instead of using a lot of medical words. We should be talking down to them. We should not be talking down to them or shouting at them or getting angry with them. We should be more of polite, and we should tell them in the way that they can understand. We should not be judgmental of their behaviors and everything. Next. So then we have to start using the 5 ways that we have seen previously during the caregiver counseling part. So first is assess. The adolescent goals for consultation is assure him of his or her confidentiality. We should assess their physical mental status, their understanding about the HIV, whether we should assess whether they are sexually active or not, and whether they are using condoms or contraception. We should whether they are pregnant or not in case of young women. We should assess for the other risk behaviors and factors for HIV transmission. We should understand their beliefs and concerns and daily behaviors in relation to HIV. We should know their support system that they have. Next. We should advise them using a plain, neutral, and non-judgmental attitude and language. We should correct any inaccurate knowledge and fill gaps in the adolescent understanding of his or her condition. Uh, we should tell them to use condom and contraception in case of prevention and to transmission to others. We should discuss about the couple counseling and benefit of disclosing HIV to the chosen people. We should have some peer support, and we should advise them on adherence also. Next. So we should advise them about the treatment plans and the options that are available and which is the simplest one. Uh, uh, So we should take into consideration of their adolescent developmental phases like Tanner scale, and based on that we should modify RDLS in them. Next. So uh, we should advise them and understand their levels of knowledge in this field. We should agree to whomever they want to choose to disclose their HIV status, on how and when they wish to disclose their status, and support whatever they need. And we should play roles on the adolescents, and other will play in their care and their treatment. We should agree on the treatment plan that has been developed, and we should agree on the goals that reflect the adolescent priorities. Next. So we should assist them and then given them a written and a pictorial summary of the plan. We should make sure that wherever they can go for services or investigations, for prescriptions, for medicines, all the support system we should give them, and we should provide them with condoms and contraceptives. We should provide skills and tools to assist their self-management and adherence. We should assist them in overcoming the obstacles, and then make sure they adhere to the medications. We should assist with their physical, mental, and social well-being, and we should assist them in strengthening the links with the friends, families, peers, and support groups and community services. Next. Next is arrange, like where so whenever they between the visits, we should make sure that they come for the next visit, and then they should they should have some support system or a group counseling. We should arrange for all those things. Next. So disclosure in adolescent living with HIV. Next. So it has a strong impact on the adherence and the clinical outcome. So disclosure encourages the adolescent to take more responsibility and participate in their own care, and it also helps in improving retention of the care. Once they understand the disease properly, they'll make sure that they continue for a long-term treatment. Adolescent, they need to be in a support system, and for disclosure of their own status and disclosure of the parental status to them. And we should always, it is important to ensure that the adolescent is ready for process of disclosure. Disclosure Disclosure process should be tailored to meet the developmental needs and understanding of each adolescent according to age. They should be able to manage their barriers. Staff should be accessible and open to answer their queries. Next. That's
Thank you so much, ma'am, for facilitating this session. Sorry, this was a lengthy session for you.
yeah.
Yeah. Any questions from the participants? Please feel free to put the questions in the chat box, or you can even unmute yourself.
There is a pre-questionnaire and a post-questionnaire registration
That
also. I
has been
hope
circulated,
you have.
ma'am. Yeah, that
Okay.
has been circulated separately due to time constraint.
Okay.
Any questions from the participant? Please unmute yourself.
So the major thing in my session is like the nutritional management. So most of the nutrition management in these children is based upon the SAM management only. So you can go through the guidelines in most of the NACO guidelines. You can go through all these guidelines. Thank you so
Thank
much.
you, ma'am. Ma'am, I don't think there are any questions. The next session
Okay.
will be held on 21st March. That's next Tuesday. And the topic is Introduction to OIs and HIV and OI-CNS. For this session, you can refer to chapter number 4.1 and 4.2 of the National Guidelines for HIV care and treatment. We'll quickly run the feedback poll. Participants are requested to please take the feedback poll. There are 4 questions in all. Please scroll through all the 4 questions and answer them. Thank you so much, ma'am, for facilitating this session. Thank you to all the participants for patient listening. We'll conclude the session now.